Myself, Dr. Amol Akhade, and we'll be talking about ASCO GI 25 in brief. I have no conflict of interest. I have used slides from ASCO GI for discussion purpose. I will try to summarize key points of the 3-day meeting in 10 minutes. I hope it will be useful for all. So to begin with, this interesting and Nivo plus EP finally got their eureka moment. Nivo plus EP as a combination has been tried successfully in various cancers, metastatic non-small cell lung cancer, metastatic RCC, HCC, but they're never able to show that the combination is better than single IO plus chemo. And most of the time, they start with 3-arm trials, but they never give the results of the 2-arm comparing Nivo EP versus Nivo alone. But this time they have hit the jackpot, and that's why they have declared the results. And the latest abstract, checkmate 8HW, in which they have previously given the results of Nivo versus chemo. Now they have given the results of Nivo plus versus Nivo alone. And it is in metastatic colorectal cancer patients who are MSI high, with some of our first line, some second line. And if you see, the progression-free survival was improved at 3 years up to 68% for Nivo plus EP arm versus 51% for Nivo alone arm. And the curves separate early and nicely. If you do a cross-trial comparison and put it above the keynote 177, and I wanted to focus on the first part of the curve of both the trials. And if you see for keynote 177, the curves don't separate for almost first 8 months, which is unlikely in HW. They separate
we
quite
can't
early.
See the curves.
And if you see the results of the, can you see them?
We can see them now. Yeah, go ahead.
Yeah. So if you see the cross-trial comparison, the keynote 177, the 3-year PFS of the Pembro arm was 42.7. So even if you have an indirect comparison, Nivo EP does better than Nivo alone itself, as well as with the historical results of the Pembro arm. So probably this is going to be a new standard of care, but as expected, the toxicity is more. And the discussion themselves have said that the toxicity rates of severe toxicity especially are nearly double. If you see here, the treatment-related serious adverse events, the Nivo EP arm are almost 55 versus the Nivo alone are 29. So there is a significant increase in the number of treatment-related adverse events. And remember, this is a trial setting, so in the real-world setting, we may have even more toxicities. But overall, this looks like practice changing. FDA has already given accelerated approval and probably will give the full approval also. But there are some unanswered questions. Should we give 2-year duration of nivolumab? Should we stop it? Or should we continue till progression? Can we add EP later and start with Nivo alone? And if required, patient is not responding, can we add EP later? We don't know the answer of these questions. Will you combine it with few cycles of chemo to tide over the initial 3-4 months of the curves when the curves are overlapping? And will you prefer this combination over pembrolizumab with a single agent? Because the Pembro data is more robust. It has 5-year OS data as of now. I conducted a small survey online, and as expected, everybody wanted to go for the Nivo plus EP. 204 people voted, and almost 83% went for Nivo plus EP. So probably this is going to be the new standard of care in this particular subset of patients. Now, the next question comes that can we give BRAF inhibitors earlier in first line for metastatic CRC? We remember that there was a trial in 2019 NG application where we used in combination with EGFR inhibitors, the Beacon trial, and we have already used this combination in second line, third line patients. Now, the question was, can we use it in first line? And that was answered by Breakwater trial. If you see the trial, they again 3 arms, EC plus FOLFOX, and standard of care. Now they have given the results of EC plus modified FOLFOX versus standard of care. And what they found that the response rates almost increased by 20%. If you dive deep, it is mainly the partial response have increased. If you see here, 42 versus 64. So the PR rates are the ones that are driving this particular difference. The CR and stable disease are more or less the same. But at the same time, there is an increase in the duration of response. So those who are responding, even if it's a PR, they are having a longer duration of response. At the same time, of course, when you're using more drugs, you're going to get more toxicity. And what has happened, the GI side effects, rash, arthralgias, and cytopenias, neuropathies, alopecia is on the more side. And what is another interesting is that what about OS? So the OS, the curves, even though are quite easily separating and there are nice gap between the curves, the predetermined statistical value of one-sided alpha was very high, and hence probably in the presentation they said that the strong trend of overall survival difference, but they are not considered as a positive trial. But what is even more interesting that weeks or the days after the ASCO GI was over, just a few days back in February 3, Pfizer has released a press release saying that the OS in breakthrough trial is statistically significant. So for all practical purpose, they are going to call this as a statistically significant OS, and most likely this will get full approval. It already has an accelerated approval, and most likely this will become standard of care for that particular BRAF mutation patient in the first line metastatic colorectal cancer. It is a very nice slide. We use it for other mutations? Answer is no. It has to be for this particular mutation. There is V600E. Can we continue the BRAF targeted therapy when the patient has progressed? Again, the answer is no. There is no role to show if you use it first line to continue beyond progression. So these are the two practice-changing trials. Moving on, in any GI meeting, there is always discussion about ctDNA. So we have a lot of trials, and the bespoke was the one was presented in ASCO GI, and it very clearly shows that ctDNA is prognostic in resected stage 2, stage 3 colon cancer. And these curves are pretty impressive to show. But important question is the point, and the presenter very nicely said that however in clinical practice, we typically order biomarker tests that have direct implication or can form specific termination decision, those that only prognostic information. These are non-randomized trials, so no definitive recommendations can be de-escalate treatment based upon the current data. So it is very nicely summarized there that is ctDNA ready for prime time in adjuvant space? It is a good marker, it is a good prognostic marker, but it is not yet effective. So probably it is not yet ready for prime time in surveillance. And we can have some discussion about this. Now, the next question, so very interesting question was that can we do drugs in the positive stomach cancer, in HER2 positive stomach cancer? And this is the trial, and I presented the overall survival results. The trial is an old trial, started somewhere in 2015. They modified in 2019 when FLOT became standard of care. And unfortunately, 3 of those results before and after modification are not impressive. So to summarize the trial, innovation trial did not meet its primary endpoint. Answer the previous question that we asked, can we add anti-HER2 drugs in the perioperative space for resectable stomach cancer? Answer is no. This only adds toxicities, and there is no advantage of adding anti-HER2 drugs. Moving on, data from India. We have a very good trial from India presented by Professor Atul Sharma, accelerated trial, adjuvant therapy or chemoradiation in gallbladder in adjuvant setting, phase 3 trial. Unfortunately, it was affected by pandemic. They tried to have a goal of 200 patients, but they could recruit only 94 patients because of COVID-19 pandemic. And what they showed that the RFS and OS, there was not much of addition of the CTRT, it doesn't make a difference. Chemo alone is sufficient. It was not powered to detect statistical significance because of the lesser recruitments. And what they have nicely summarized that lacks the statistical power for primary endpoint, lack of stratification, not compared with the current standard of care, that is BILCAP. But probably it says that one more organ in GI where role of RT is going down and down, and probably in resected gallbladder, the role of RT remains only in selected cases where there is R1 resection. Otherwise, there is not much role of adjuvant RT in a resected gallbladder cancer. That another data from TMH, the similar question that trastuzumab TM1 can be used as a second-line therapy in HER2 positive advanced biliary tract cancers. Conclusion was, again, the TDM1 addition in the second line for BTC patients, those who received prior anti-HER2 therapy did not have any much role. And we have now 2 trials, one in stomach, one in gallbladder, to show that anti-HER2 doesn't add much. And probably the reason is that the use of benefit of residents, that HER2 in breast is different from HER2 in stomach and BTC. It is not driver pathway in these tumors, and other strong pathways like KRAS and EGFR will make anti-HER2 drugs less effective in these tumors. moving on, I'd like to show you last two slides, what we call as the money slides. Madam was talking about ESOPEC trial. Dr. Bhavana was talking about that. So this is a very beautiful slide presented by Dr. Nia Stanford about what is the, after ESOPEC trial, what is the current standard of care. And I want all the residents to have a look at this. So esophageal cancer, it is a first patient is a surgical candidate versus non-surgical candidate. Non-surgical candidate, definitive chemo-RT. The dose of RT is around 50 to 54 grade. There are various trials to show that dose escalation has been not much useful. So we generally, it is definitely CTRT. We stick to the dose of 50 to 54 grade. And the paclitated carbo is preferred over FOLFOX. If the patient is a surgical candidate, small cell, that it is squamous cell carcinoma, then we go for chemo-RT, surgery, and if there is a residual disease, go for nivolumab, especially if there is a no PCR, nivolumab for 1 year. If it is adenocarcinoma, a patient is FLOT eligible, will go for FLOT 4 cycles. Consider pre-op chemo-RT if poor response to FLOT or risk for R1 resection. That means the patient has received neoadjuvant FLOT but not showing good response. One may add RT. After surgery, one may add post-op chemo-RT if margins are positive, poor response to FLOT, or extensive lymphadenopathy. Otherwise, one can complete adjuvant 4 cycles of FLOT. So this is a very good slide to summarize the current standard of care for G-junction esophageal cancers. And the last slide from my side, the role of CAR-T for GI cancers. This is a very upcoming topic. And as the heading says, the role of CAR-T for GI cancer as of now is absolutely minimal. This is a very nice summary table to show all the CAR-T trials which has happened in the GI cancers. The number of patients are very less. The response rates are not great. Some recent trials presented in ASCO 2024 have some response of 39% and all. But if you see modified PFS is not more than 4 or 5 months. So
great. Thank you, Dr.
CAR-T,
Amol.
you should restrict to the clinical trials alone.
Thank you so much. Thank you.
That's the last slide.
Thank you. So we'll not